Hi, my name's David Pattison. I'd just like to thank the organising committee for inviting me today to speak to you about Back to the Future, theranostics for thyroid cancer. Today I'll be talking about the role of I131 therapy decision making with risk stratification, I124 PET theranostics, including different methods of TSH stimulation, the definitions of radioactive iodine refractory disease, the role of redifferentiation therapy in the iFirst study, and I'll briefly touch on the role of FDG PET and thyroid cancer. So, as many of you would know, radioactive iodine was actually the first targeted cancer therapy as developed by Saul Hertz and Sam Seidlin back in the early 1940s, and which has been the foundation for nuclear medicine as we practice it today. But there has been a trend in more recent years with reducing radioactive iodine use, particularly for low and intermediate risk disease, with studies such as this one showing non-inferiority of omitting radioactive iodine in patients with low-risk thyroid cancer, and also increasing report to the risk of haematologic malignancies after radioactive iodine, which have really tempered the use in patients with low-risk disease over the last 10 to 20 years. And what we also know, though, is that up to 85% of patients are actually cured with their primary treatment, and therefore the key role of radioactive iodine is in treating that 15% of patients with either recurrent or metastatic disease, where in fact treatment escalation is what is required. And this really leads us back to the future, where we're going back to those early days in the 1940s and needing to better utilise high-dose radioactive iodine for the patients with the more severe end of disease spectrum. And so how do we risk stratify for decision-making about using post-operative I131? Well, they should all be familiar with this table in the ATA guidelines. We know that although it's very clear for those patients at lowest risk that we don't use radioactive iodine, there's this large group of patients with intermediate risk where there's limited guidance about the use of I131, and then of course those patients at high risk where treatment is mandated. And I'm sure you'd also be familiar with this, with patients similar to those in this slide, where a use of blind radioactive iodine can lead to these outcomes, where I'm sure the patient on the left would be wishing we hadn't treated them with radioactive iodine, and the patient on the right, the question would be whether or not we could have given them a higher dose. And so the two main methods that we have at our disposal are the use of either a pre-treatment radioactive iodine scan, which I'll elaborate on in coming slides, but also just draw your attention to the role of a post-operative thyroglobulin measured at 6 weeks following surgery, which can help to assess for either persistent disease or a normal thyroid remnant, and risk stratify the use of radioactive iodine. Moving on now to talk about the role of I124 and how that can be used in theranostics, which is a term that all of you will be familiar with, being the prediction of response to a therapy using a diagnostic test. And the key benefit, as you can see here, is that we can use a diagnostic test such as an I124 PET scan to demonstrate the uptake and intensity and distribution within the patient. If patient is deemed suitable, we can then proceed to treatment with the therapeutic isotope of I131, and then revert back to a diagnostic scan for follow-up and restaging. And of course the benefit is if the patient becomes positive again, we can then retreat with the same therapy. But also importantly, if at the outset, if the patient isn't expressing the target, you can avoid what we would know as a futile treatment. You'd also be familiar with the evolution of thyroid cancer imaging over the last 40 to 50 years, with the image on the left being a planar whole body scan, not dissimilar to that what would have been used in the 50s and 60s. We've then had the advent of SPECT with three-dimensional representation of the activity, SPECT-CT with low-dose CT for co-registration and localization, and then much more recently the use of I124 PET with much greater imaging resolution and also the potential for prospective dosimetry. You can see here this is a description of the three main medical isotopes of iodine, with I-131, which is used for therapy and also lower quality imaging, has resolution of planar and SPECT, and of course there is the potential complication of stunning if used for a diagnostic scan. I-123 is used less commonly nowadays, is only an imaging agent, similar resolution to the therapeutic isotope but without the risk of stunning, but it's limited by a short half-life of 13 hours, which limits it to just a 24-hour diagnostic whole body scan. On the right-hand side you can see I-124, which has the benefits of not only high-resolution imaging with PET, but also that potential for prospective dosimetry, a theoretical absence of stunning, and a half-life of 4 days, which enables serial time point imaging for prospective dosimetry. Also just remind you of the requirements of an adequate radioactive iodine scan, including TSH stimulation above 30, no exogenous iodine exposure, and either high dose I-131 or lower dose I-123 or I-124 studies. So with pre-therapy imaging, with the use of either I-131 or I-123, there have been several small retrospective studies that have shown potential management impact in up to 25 to 50% of patients. Of course, if this is positive, then there's a potential to increase the administered activity or plan a 2-stage ablation for large thyroid remnants. But the major limitation is that there's significantly reduced sensitivity for detection of distant metastatic disease, with a sensitivity of approximately 40 to 60%, particularly for lung metastases, when compared to a post-therapy scan. And so the major issue or outcome of this is that if you do have a negative pre-therapy scan, then you can't confidently omit a planned therapy. And several authors have suggested there's no additional diagnostic value to thyroglobulin. In contrast with I-124, when given as a low activity, there's minimal risk of stunning. And from this large study out of Germany, it's shown that a low-dose I-124 PET accurately predicts a post-therapy high-dose I-131 scan. So this is a study out of 140 patients with nearly 230 metastases, where the same method of TSH stimulation was used, and it showed a very high level of agreement of 97%, confirming its use in this setting and clearly superior to an I-131 diagnostic scan. The challenge, though, is choosing the right method of TSH stimulation. And there was a key study, the ThyroPET study, which was a large prospective trial asking the question, does thyrogen-stimulated I-124 predict the outcome of a thyroxine withdrawal post-therapy scan? And the answer was an emphatic no, with the study stopped early after just 17 of 100 planned patients, because of the 9 patients who had disease evident on their post-therapy scan. Disease was only seen on 4 of their I-124 PET studies. And furthermore, there was a subset of patients who had an I-124 PET at baseline and also after thyroxine withdrawal, and on that subsequent scan showed up to 20 times greater dosimetry. And so in terms of the explanation for that discordance, several authors have said it's most likely due to the method of stimulation, because we know that low-dose PET scan has got a similar or higher resolution than a high-dose I-131 study. Furthermore, numerous case reports have shown similar findings in the literature. This relates to my own personal experience, where we had a young executive who was travelling from Sydney for serial thyrogen-stimulated PET studies. I saw him in 2016 with a negative scan, but with a thyroglobulin in the hundreds. And with awareness of that recently published study showing the limitation of thyrogen-stimulated studies, I told him that scan was really suboptimal, and I recommended he come back for a PET scan with thyroxine withdrawal. And as you can see here, when he did so, the images showed multiple intensely avid metastases and clearly, in this case, demonstrated the superiority of using thyroxine withdrawal. So in terms of our approach to imaging at the Royal Brisbane, we use serial blood sampling to assess the maximum tolerable activity. We also evaluate for lung toxicity at that activity and can perform lesional dosimetry, measuring the activity within the lesion of interest over time to ensure that that activity will have a therapeutic effect. So our Queensland Health New Technology Funding Evaluation Program grant set up this multidisciplinary imaging protocol, including evaluation of management impact with either high, moderate or low impact, and also cost effectiveness. I won't go through this data in any great detail, but as you can see on the right hand side, it does show that there was high management impact in nearly half of the patients, which involved intermodality change, i.e. from planned treatment to omission or commencement of chemotherapy, and medium impact in a further 33%. This is an example of how we used I124 PET. This is a patient with metastatic Hürthle cell carcinoma with an intensely FDG-avid superior mediastinal node, and as you can see with the I124 PET scans at 24 and 96 hours, there was no uptake demonstrated at that site, and so this patient could avoid futile treatment with the use of this technology. In contrast, this is a patient who had metastatic thyroid cancer to the liver as well as regional nodes, and treated successfully back in 2011. In 2018, he had a lesion in the pancreas identified on CT, and following I124 PET, we were able to confirm that was in fact an unusual site of metastasis, and also enabled prospective dosimetry to effectively deliver radioactive iodine therapy. This is another case of a patient who had, mildly FDG-avid follicular thyroid cancer with metastases to the lungs. She underwent an I124 PET, which really showed suboptimal activity there to recommend treatment, and that treatment was avoided. Just moving on to the definitions of radioactive iodine refractory disease now, and this is another key feature of I124 PET, which I think everyone should be familiar with. Just outlining, I've highlighted the three main criteria that were confirmed in the SELECT study, validating the role of lenvatinib. So this is either having non-iodine avid measurable disease, or in the setting of patients with iodine avid disease, showing disease progression despite treatment in the last 12 months, or having a cumulative I131 administration over 22 gigabecquerels. So this is the first case I'll demonstrate. This is showing no radioactive iodine uptake in metastases at that initial treatment. You can see on that FDG PET, very intensely avid extensive disease, and then following thyroidectomy, absolutely no iodine uptake on that post-treatment scan, and this is clearly refractory to further treatment. This is a case of disease heterogeneity, or what you'd be familiar with as the flip-flop phenomenon, where there is just complete discordance between that disease. You can see this supraclavicular node, which is intensely iodine avid, but with absolutely no FDG uptake, and the converse is seen on the left-hand side. And down when we look through the thorax, you can see this very intensely FDG avid invasive disease extending into the spinal canal with absolutely no iodine uptake, and in this case clearly radioactive iodine treatment is futile, and this is radioiodine refractory disease. The third case shows that despite there being initial avidity, that is subsequently lost over time. This patient, you can see quite intensely avid pulmonary metastatic disease at baseline in 2009, but with subsequent treatments we're seeing progressive reduction in that retention of iodine until the scan that's performed in 2015, showing clearly structural disease on the CT but minimal uptake on our post-I131 study. Now, for the last two cases, these are patients that do actually have iodine-avid disease, but in this case showing progression despite treatment less than 12 months prior. On the FDG PET, there's no significant disease evident, but with subsequent I-131 treatment in January, we can see these intensely avid foci. When treated again in September, we can see an increase in the intensity of the avidity, and on a follow-up PET scan, we've actually seen that there has been progression of that disease with an FDG avid focus there, and that is mirrored in that serial, progressive rise in thyroglobulin despite that treatment. The final case is the most controversial, and this is just showing a cumulative activity being greater than 22 gigabecquerels. This patient, widely metastatic disease with numerous treatments over 4 years. And there has been, generally you can see a reduction in thyroglobulin after each of those treatments. As I said, it's controversial whether or not there is clinical benefit with further treatments, but I'm sure you'd agree that it's likely had an alteration of that patient's expected disease course over time. But again, the jury's out on whether it's the right time to call time on further treatments, but this is one of those criteria that were established for the SELECT study. And so where to now? I'd just like to present our exciting update on the iFirst study. Many of you would be familiar with this study that was published in the New England Journal of Medicine in 2013. It was very exciting to show the role of MEK inhibition to restore iodine avidity in patients with RAI refractory disease to facilitate further treatment. So of this small study in 20 patients, the use of I-124 PET was able to demonstrate an increase in uptake in 12 of those, of which in 8 the activity was above a dosimetry threshold that enabled these patients to proceed with radioactive iodine treatment. And there was a significant reduction in thyroglobulin in all patients, with a mean reduction of 89%. And most importantly, all of the patients who had an NRAS mutation demonstrated uptake greater than that dosimetry threshold and proceeded with treatment. So down at the Peter Mac, I used this information with the team when establishing the redifferentiation protocol in 2015. And our approach was to treat with a MEK inhibitor all patients with an NRAS mutation, and to use a combination of trametinib and dabrafenib in those patients with a BRAF V600E mutation. So this was a novel protocol, also because it was the first study that used thyroxine withdrawal as a method of TSH stimulation in this setting. And we published these results a few years ago, which showed all 3 patients treated with who had the BRAF mutants, and 1 of 3 patients with the NRAS had a satisfactory response to treatment. And here's 2 of those cases where clearly you can see iodine refractory disease on the baseline I-124 PET study, with really very satisfying response to redifferentiation therapy, enabling further I-131 treatment, and there are the thyroglobulin responses demonstrated. And this brings us back to case 3 that I showed you earlier, and this is how we managed this patient up in Brisbane. Following that last I-124 PET, we analysed the patient's baseline histopathology. It confirmed an NRAS mutation. She proceeded to 4 weeks of treatment with trametinib and thyroxine withdrawal, and on repeat I-124 PET showed very intense iodine uptake, and then we successfully treated her with radioactive iodine subsequently with a good therapeutic response. And so this approach has led us to the iFirst study, following receipt of a $2.7 million MRFF grant for a large multi-centre Australian trial. And this is currently going through governance and is opening imminently at these sites, so including 4 sites in Melbourne, including the Austin, Royal North Shore in Sydney, Royal Brisbane, and Sir Charles Gardner Hospital in Perth. So we've got funding to screen 150 patients, and we'd anticipate to enrol 80 of those onto the study with the expected number of mutations. So again, this is drawn on our prior experience with a novel study design, treating patients with RAI refractory thyroid cancer with progressive disease as determined by RESIST within the prior 12 months, and selective use of tyrosine kinase inhibitor redifferentiation therapy for NRAS and BRAF mutants. We're using thyroxine withdrawal and prospective dosimetry using I124 PET, with the primary endpoint of assessing progression-free survival at 6 and 12 months after therapy. This is a brief outline of the study schema. So patients will have FDG PET prior to thyroxine withdrawal, then be evaluated with both I124 and FDG PET studies. These will be centrally reviewed before the patients proceed to further thyroxine withdrawal, coinciding with 4 weeks of TKI treatment before repeat imaging and dosimetry PET studies. If there's adequate iodine uptake, they'll proceed to I131 treatment, and then we'll have serial follow-up with further FDG PET for response assessment, as well as diagnostic CT studies. And finally, just to briefly touch on the role of FDG PET in thyroid cancer. I'm sure you'd be aware of the indications as defined in the ATA guidelines. So the key indication being that of patients with high-risk disease with a thyroglobulin level above 10, despite negative iodine imaging, but also has a role in initial staging of poorly differentiated and oncocytic or Hürthle cell carcinoma, for metastatic disease, for initial staging and prognostication, and also for response assessment following systemic or local therapy. And one of the key roles is that this was shown in a study out of Memorial Sloan Kettering Hospital. It was a large study, although retrospective, in 400 patients with a median follow-up of nearly 8 years. And it was an analysis of all known prognostic indicators, including age, initial AJCC stage, histology, use of radioactive iodine, and of course FDG PET. And it was looking to identify patients and lesions at risk of rapid progression. So on the y-axis, we can see overall survival and a very clear demarcation based on the presence or absence of FDG avidity. We can also see that this avidity, stratification holds irrespective of iodine uptake and is stratified according to SUV max. And the key role that I use this in practice is that although patients may find it, patients and clinicians alike are sort of hoping to identify disease to determine the next treatment course, I find it's actually very reassuring, and to flip the results on its head, because if you do actually have a negative scan, it's actually much more reassuring to tell the patient that they're in fact lucky, because there's a 90% survival at 5 years, as opposed to the alternative. So in conclusion, I'd just like to reiterate that radioactive iodine decision making includes both clinico-pathologic factors, but also the use of an unstimulated thyroglobulin and pre-therapy iodine imaging. Our preference is certainly to use I124 PET for that at Royal Brisbane, and this has got increasing use around Australia, particularly with the iFirst study. I've shown that it accurately predicts your post-I131 therapy imaging when using thyroxine withdrawal, but importantly, the converse isn't the case when using thyrogen. It provides prospective dosimetry to guide I131 activity, and from our study has shown high management impact, particularly in avoiding futile treatment. It also has a very important role in defining radioactive iodine refractory disease. And I'd reiterate the importance of you all to look for this on post-treatment scans, because it has significant impact in determining suitability for TKI therapy such as lenvatinib. I'd also like to reiterate the exciting news about the opening of the iFirst study and that novel study design dependent on whether patients have got an NRAS or a BRAF genetic mutation. And finally, I'd just like to highlight that with the use of FDG PET, Not only do we use that to identify sites of disease that are not targeted by radioactive iodine, but just to reiterate, the benefit that a negative scan actually indicates a very good prognosis for our patients. So I'd just like to thank you for your attention and would welcome any questions.